Hello, and welcome to the Duke Endocrinology Conference. I'm Diana McNeill, Professor of Medicine at Duke University Medical Center. Today's program is titled Protecting the Kidney in Patients with Diabetes, and our distinguished guest is Eugene Kovalik, Associate Professor of Medicine at the Duke University School of Medicine in Durham, North Carolina. Gene, thanks so much for joining us.
My pleasure.
So, Gene, what can you tell us about today's topic, protecting the kidney in patients with diabetes?
Well, my practice these days is rife with patients with diabetes and kidney disease. And it is the most common cause of being on dialysis in this country. Roughly almost 50% of patients now starting dialysis have diabetes as their cause of their renal disease. But with that, 100% of them also have hypertension. And so I think by looking at both those areas, treating hypertension, you'll help the diabetics stay off dialysis as long as possible.
So, Gene, you and I over the years have had the opportunity to share in the care of a number of patients. And just to personalize your conversation with us today about diabetes and kidney disease, I wanted to remind you of a patient that we shared the care of, a 45-year-old woman with type 2 diabetes for almost 15 years, who had hypertension that we were managing, and then we were routinely checking her urine for protein, and all of a sudden she started spilling large amounts of protein. Her creatinine bumped a bit, and into the 1314 range milligrams per deciliter. And I sent her to you because I was concerned that we were starting to see progressive renal disease. Can you share with our audience if I did the right thing, what their thoughts should be on referral of patients with diabetes to the nephrologist, and then how you can help us think a little bit more about things we can do as general internists and endocrinologists to help these patients do well with their diabetes and kidney disease?
Okay, well, I think it's one of the biggest things we like in nephrology is early referral. And the reason is that when you wait till your patient's creatinine is 2, which, is now abnormal in most lab reports, they've lost more than 50% of their kidney function already. So in that case, the horse is out of the barn, as they say, and what we can do is try and prevent further damage and slow progression, hopefully to the point where they never have the need for dialysis therapy. Okay.
So you're going to tell us why we need to treat all of this to start with.
Exactly. So unfortunately, with the aging baby boomers, the number of patients who are developing diabetes is increasing, mainly because they're all getting bigger as well as getting older. And the problem is, in past years, patients with diabetes often died of a cardiovascular event in their 60s and never live long enough to get the kidney disease. But our cardiology colleagues have been so successful in treating coronary disease that now they're living the extra 10 or 15 years it takes to develop diabetic kidney disease. And as a result, now we're having a huge influx of patients into our practices. And unfortunately, there are not enough nephrologists to go around to see all these patients. We actually aren't training enough nephrologists. So it's very important that primary care physicians and endocrinologists taking care of these patients assume a lot of the responsibility for managing blood pressure control and their diabetes. So
far in a very short period of time, Gene, you've said blood pressure control at least twice, and I'm going to guess that that's going to be sort of the message that's going to be shared throughout your conversation with us today.
Exactly. As you can see in these graphs here, this is from the United States End-Stage Renal Disease Database that tracks all patients on dialysis, and this really tells you how severe the epidemic is going. In the top graph is the number of patients on dialysis in thousands, and the lower graph is the actual rate per million of population. And as you can see, the groups that are really taking off in numbers and incident rates are the older population group, particularly the over 65 group, and more recently the over 75 population are blossoming and booming in our dialysis units.
I guess some of us wondered if there was an age cutoff for dialysis.
There is absolutely no age cutoff for dialysis. My oldest patient is 94 years old now. He started when he was 90 years old.
Oh, my goodness. Oh, my goodness. I think that was maybe a medical lore that a lot of us had in our teachings in the past.
Well, with the success of dialysis technology and the cardiac care patients are getting, there's really no reason a reasonably healthy older person cannot have dialysis therapy.
Okay.
So as you can see, as we mentioned earlier, diabetes is the #1 cause of people starting dialysis. The upper graph, again, number of patients in thousands with diabetes on dialysis, and the lower graph, the incident rates per million of population. So diabetes, is almost double the incident rate of just pure hypertension. But you have to remember, everybody with diabetes on this graph has hypertension.
That's a good point. And just for our audience, what is cystic kidney disease? What are you talking about?
Cystic kidney disease are mainly the polycystic kidney type of patients. And being a genetic disease, it's really a fixed number of patients who have that per year. And actually, and more interesting, if you look at the graph, the glomerulonephritis, the fancy disease that we spend so much time being tortured with in medical school,
that's true,
are actually a small number of the total starting dialysis, and fairly constant number.
So again, third time you've said it, diabetes and hypertension intrinsically combine together to cause a problem with progressive renal
That's
disease.
correct. They go hand in hand. And unfortunately, hand in hand, certain patient groups are actually affected more severely by these problems. If you look at patients who are on dialysis, Caucasians outnumber African Americans, but more importantly is the lower graph, the incident rates per population group. And the African American population, as you can see, is affected 3 times as much by end-stage renal disease, particularly from diabetes, compared to Caucasians. So it's a smaller number, but significantly higher rates of problems with diabetes and hypertension causing need for dialysis therapy.
So it's important that we get the message out to all groups of patients about the importance of early detection.
Correct. And so early detection with hypertension and also with diabetes, and the two together will have a great effect on lowering the number of patients having progressive kidney disease.
I know in the diabetes world, the American Diabetes Association has had similar graphs that you're showing, and so there's been an intensive educational initiative for African Americans, Native Americans, and others who are high risk for diabetes. I suspect that the same group should be educated about hypertension management.
Correct. Correct.
Okay.
And the reason we really want patients to avoid starting dialysis is this table here, which actually shows you the expected life years left once you start dialysis.
So there's lots of numbers on this table, Gene. How could you summarize
the
this?
best way is to look at somebody who's 60 years old on the far left of the table. And basically, if you're 60 years old, if you look at the general U.S. population, most have 21 years of life expectancy left.
Okay.
So compare that to once you start dialysis, the life expectancy drops significantly. So if you look at sort of in the center for African Americans, if you start dialysis and you're 60 years old, you have about 4.8 years of life expectancy left.
Oh, my goodness. So is this why sometimes the nephrologist will do everything possible to bridge in certain situations to transplant to avoid dialysis?
Exactly. And transplantation, is great. It does increase life expectancy, but again, it does not bring life expectancy to normal. If you are 30 years old and the normal population and you're 30 years old, according to this graph, has at least 45 years of life expectancy left. If you are transplanted, that drops down to 20 years, 30 years. So you don't have the full normal life expectancy with a transplant. It is much, much improved, but again, it's not normalized. And again, the patients don't die from their kidney disease in these cases. They all die from cardiac disease. So again, treating hypertension and diabetes will help reduce those risks.
So coming back to our initial patient who's 45 years old, has 10 plus years of diabetes, now starting to show some evidence of obvious nephropathy, it is prudent and appropriate to even at a very early stage intervene in order to try to add extra years to her life expectancy. Is that correct?
That's correct. For every year that you keep them off dialysis, you are really increasing life expectancy tremendously.
Okay, good.
So I think when we continue our talk, as screening is a very important thing with patients with diabetes, and most of your patients are always screened for albuminuria.
Okay.
I think it's important to just go over definitions because it gets confusing depending if you're talking in micrograms per minute or milligrams per day. Often people sometimes use those interchangeably and not quite the same. So a normal person will have less than 20 micrograms per minute of albuminuria, which translates to 30 milligrams per day when you multiply it out. A patient now has microalbuminuria when they have between 20 and 200 micrograms per minute of albuminuria, or 30 to 300 milligrams per day. And frank diabetic nephropathy is when you have microalbuminuria, which is over 200 micrograms per minute or 300 milligrams per day. If you look at total urinary protein, which is different, a normal person should have less than 150 milligrams of total protein per day in their urine. And most of that is albumin.
Okay. So let me tell you the question that every health officer asks me. If you already have a urinalysis that has 2+ or 1+ protein in there, is there any reason to do a microalbumin?
There's many reasons. First of all, the urinary dipstick can have a lot of false positives. If somebody's very dehydrated and has a very high specific gravity, those proteins can be concentrated down and give a false positive dipstick. I've seen many patients with 2+ protein, when we actually do the real testing, don't have significant protein. So they often will have a false positive test. And so if you do have a positive urine dipstick, then you have to go on to the further testing. And again, even when you do further testing for urinary microalbuminuria, certain conditions can give a false positive rating. For example, bad urinary tract infection or uncontrolled diabetes.
Or menstrual cycle.
Or menstrual cycle. So if you have a positive urine albumin, you have to repeat that several times in the space of several months to confirm that it is persistent and true.
Is there any special time of day you should check that urine, given the direction your care will begin to go if it's positive?
I don't usually check any particular time of the day.
And I don't see on here a request for a 24-hour urine. So a lot of our primary care physicians have been taught, particularly with their diabetes, patients with diabetes, to check 24-hour urines for protein. Is that necessary anymore?
These days with the urinary protein or urinary albumin and creatinine ratios, they are fairly consistent, and you can use them to follow somebody. It is extremely inconvenient for patients nowadays to do 24 urines, and I almost never do that anymore in my practice or nor my colleagues because it's just inconvenient. The only time we're really doing 24-hour urines if we want to check a real creatinine clearance.
Okay. And then I don't hear the word creatinine anywhere in your discussion.
Well, that's because creatinine is a good marker, and it is used in the basis of the eGFRs that are always showing up now in your lab test. But creatinine is a very dependent variable in looking at kidney function. And the biggest problem is creatinine is a reflection of muscle mass.
Okay.
The bigger the muscle, the patient with more muscle mass, the higher the creatinine is to begin with.
Okay.
And so the problem, which I try to teach a lot of the house officers, is don't look at the creatinine by itself, but look at the patient.
Right.
Because a little old lady who weighs, 100 pounds has a creatinine of 1, which is technically in the normal range, actually has significant renal dysfunction.
Okay.
And so the creatinine by itself is not an isolated value, but has to be taken into account with the patient's overall appearance.
Gene, I'm reassured that you still tell us we need to go and examine the patient. That's always important.
Exactly. And actually the other important thing to know is that the eGFR,
what is eGFR? Just for our
estimated glomerular filtration rate, which is based on the modification in diet and renal disease study, is now showing up to try and prompt people to see that patients have kidney disease.
Okay.
The problem with the eGFR is patients with normal kidney function, it falsely gives a falsely low value.
Okay.
And so you have to, again, if somebody has really normal kidney function, they can have a low GFR just by the vagaries of the test and the way the numbers were done originally.
So always look at the patient.
Exactly.
Always look at the patient. All right.
So what's the natural history of diabetes in the kidney? Well, you have to kind of look at two different patient groups. In type 1 diabetics, because we really know when time 0 was when they started their diabetes, when you look at them, they actually have an elevated glomerular filtration rate at the time of their diagnosis. And that's because the sugars are so high, the sugar acts as an osmotic agent and causes hyperfiltration through the kidney.
Right.
And as time goes by and their diabetes gets under control, that comes back down to normal. And everybody in general has a reserve in their glomerular filtration rate. If you eat a steak, for example, nice big steak, your glomerular filtration rate will jump 30 or 40 milliliters per minute.
And I can assure you I'm not thinking about that while I'm eating the steak, but that's okay.
and then as you clear off, the protein load, it comes back down.
Okay.
If you look at diabetics over time, as their disease progresses, one of the early signs they really have intrinsic diabetic kidney disease developing is that they lose that renal GFR reserve when they have a protein load, such as a steak meal. So that's one of the earliest signs, not that we actually check for that.
Okay.
And eventually, then they just start declining their GFR completely.
Okay.
But type 2 diabetics are a different breed, mainly because they've probably had diabetes for quite some time, and so they're already often into the course of their disease at the time of their diagnosis.
So our patient, even though she's been told that she maybe has had it for 10 years, may have had it for 5 to 10 years prior to coming to diagnosis, so that her renal history is a little bit longer than what we may think if we just look at the dates on it.
Exactly, because her diabetes is not being treated for quite a few years.
Yeah.
It's already set the wheels into motion in the kidney.
Okay.
And if you look at patients with kidney disease and diabetes, we see lots of diabetics, and we're asked to evaluate them for proteinuria. Well, one of the first things we always ask is, do you have retinopathy? If you have a diabetes with retinopathy, then 90% of the renal disease is due to the diabetes.
That is a pearl.
That's a pearl.
That's a pearl.
But interestingly, they did some studies and looked at those without retinopathy, and even patients without retinopathy, 70% of those, the disease is usually due to diabetes.
Okay.
And if you look at ultrasounds in these patients, as the kidneys are hyperfiltrating early on in the disease, diabetic patients have very large kidneys. And as time goes on, the disease progresses, they get scarring, and they start to shrink down.
So one of the questions that comes up a lot for our primary care physicians is if they have a patient with retinopathy and proteinuria, either micro or macro, how much workup should they do to look for other causes of renal disease? Or is it acceptable to just use your statistics here and say, diabetes is the most likely cause?
You don't want to spend too much money on lab work, but the basic workup, everyone gets an ultrasound just to make sure they have 2 kidneys and there's no obstruction issues, or by chance they actually have cystic kidney disease that they never knew about.
Right.
Depending on their age, if they have some anemia, then we may look at an SPEP and a UPEP. And that's really about
Checking for multiple myeloma.
And the other thing is they have hematuria, then they need further workup, particularly if you see red cell casts. And depending on the length of time they have diabetes and the amount of protein in the urine, they may need further workup. I mean, if they're spilling 5-6 grams of protein and they haven't had diabetes for more than a few years, there may be another underlying glomerular process going on.
Okay.
But in those cases, that's when they should be referred to a nephrologist to help sort that out.
Good. Very helpful.
And so, often you're asked, what's the timeline for proteinuria? When do the patients first show up with proteinuria, and how long does it take to progress? And if you look at type 1 diabetics, really 40% of them will have some renal involvement after 20 years of diabetes. That does not mean that they'll have renal failure, but they will have renal involvement. But if you look at all comers, progression from normal albuminuria to microalbuminuria is about 2% per year.
Okay.
And then once you develop microalbuminuria, the progression to macro is about 3% per year. And then once you hit macro and develop CKD, chronic kidney disease, defined as a creatinine of 10 in these studies, then you're about 2% per year convert to progressive kidney disease. But in general, both type 1 and type 2, but up to 60% of patients will progress over 5 to 10 years. So for type 1, you may wait the full 10 years. For type 2, it may be 2 or 3 years because they may have had disease for 5 or 6 years already.
That's an extremely important point. So patients ask this all the time. Am I safe if I've had diabetes for 30 years and I don't have microalbumin from getting diabetic kidney disease?
Depending on your age, you may be if you're 70, but if you're 30 or 40 and you had diabetes since age 10, not yet.
Not yet. Okay.
Not yet.
So it's still important to control the blood pressure.
Yeah.
Okay.
Exactly. And the reason is once you get microalbuminuria, you're on dialysis often about 10, 15 years later.
Okay.
So if you're a young person with diabetes, especially now where you're seeing more and more type 2s presenting at an early age, they're looking at potential dialysis in their 60s.
Okay.
And the important thing also for albuminuria is these days, not only is it a reflection of kidney risk, but it's an independent risk factor for cardiac disease, which nobody would have thought of in the past.
No.
But if you look at the annual cardiovascular mortality, for normal albuminuria, it's 1%. Once you have micro, it doubles to 2%. Once you hit macro, it doubles again to 4%. And once you actually get CKD, then it's up to 12%. So it's almost exponential in its rise. And so why do we control blood pressure? If you don't control blood pressure in diabetic, they will lose 12% or 12 cc's of GFR per year. So 1 cc a month. Okay. Now, normally after the age of 40, everybody will lose GFR. That is part of aging. But this just is a much accelerated rate. And as we'll see, if you control blood pressure well, to 130 over 80 goals, the progression of renal disease can be cut down tremendously. For example, you can slow down the decline from 12 milliliters per minute per year of GFR to maybe 2 to 4 milliliters per minute, so 1/6 to 1/3 the amount.
That's impressive.
Progressive rate.
That's an impressive improvement.
Yeah. And this is actually shown by this graph. This is a sort of an amalgamation of many studies done by Baccaris. And if you look at uncontrolled hypertension, which is theirs really 160 over 100, what it translates to.
Truly uncontrolled hypertension.
The progression rate is 12 milliliters per minute per year of GFR.
Okay.
If you just get it down to 140 over 90, which is not even to goal these days, but the old goal for patients without any other disease, you cut the rate in half to 6 milliliters per minute per year. And in most of these studies, they actually can get the pressure down to 130 over 85, and they're getting down to the 2 to 4 milliliters per minute per year progression rate.
So, Gene, one of the things that we struggle with as primary care physicians and endocrinologists refers back to our patient. So her blood pressure wasn't at goal. When presented with that information, as many patients do because of some of the information they received, she said, can I try diet? Can I get rid of salt? Can I exercise? And by the way, I'm pretty sure I have white coat hypertension. Given the graph you just showed, and I think some of the information you're going to share with us now, what should we do with that kind of a query? Should we say that's not worth it given what you just showed as the improvement? Or? Well,
lifestyle modifications, if they can't do anything major in 3 to 6 months, then it's not going to be much use.
Okay.
And most lifestyle modifications, if you look at Laura Svecki here at Duke, looking at the DASH diet studies, you're getting maybe 3, 4, 5 millimeters of blood pressure lowering. And most of these patients need 10, 20, 30 millimeters of blood pressure lowering. So diet's important in terms that it'll help to maintain and to help lower the pressure, but it's not going to be done without usually medication. If they want to try diet modification for 3 months while they're still on their baseline medications, I usually let them, as long as their pressure is not severely elevated. But they will need significant medication to get the pressure to go.
And significant follow-up. I think that's the one thing for the
exactly.
people that are listening to you. I mean, we can't just tell them to come back in a year and we'll check it again.
No,
the graph.
These patients will often require you to see them maybe once a month.
Okay.
I mean, it doesn't have to be you necessarily, but one of your nurse practitioners or physician assistants. But with blood pressure checks, you can do a lot of the monitoring and adjustments without full office visit. And depending on the patients, often if they're reliable to check the pressures at home, they can. I have some patients actually email me, and we kind of do this over the internet.
Okay.
But one thing I like to tell patients is that the blood pressure by itself is extremely important. If you look at studies looking at diabetes and progression to renal disease, and one of them, for example, is the IDNT, which is irbesartan and diabetic nephropathy trial, which looked at patients getting irbesartan, which is an ARV, versus a dihydropyridine calcium channel blocker-based therapy. Of course, the patients on the ARV had slower progression to disease. But when you look at the data and just stratify it to blood pressure groups, it doesn't matter what therapy you're on, the lower the pressure, the better, the slower the progression to renal disease in this case.
And that graph is profound there with the blood pressure of less than 132.
For every 10 up of systolic, you have a significant bump up in the progression rate.
So I'm not keeping count, but I think we're up to 6 times you've said we've got to get the blood pressure under better control.
Exactly.
And I think, and the pearl here is no matter what it takes.
No matter what it takes.
Okay.
And as a nephrologist, I kind of jab at the endocrinologist.
You certainly are.
That if you look at all the studies, tight blood sugar control versus tight blood pressure control on cardiovascular endpoints, blood pressure control, especially given the cost and time involvement, gets the biggest bang for your buck.
Right.
And in this summary slide by Baccaris, which was published in 2000, you can see the risk reduction of one versus the other.
And it took about 9 years for the diabetes groups to agree that we need to be very aggressive with blood pressure control, probably more than even glucose control. But I want to put in the plug here. We're not ignoring glucose control,
I think
right?
Glucose control has significant benefits in terms of how patients are feeling, their thirst, and with the thirst, salt and water intake, and effects on the immune system,
That's right.
wound healing. So all those are important as well.
Right. Good.
But like you said, it takes a lot of medicines.
Ooh.
On the aggregate studies, it took up almost 4 different blood pressure medications to get pressure to goal. And most of these studies actually didn't quite get to goal.
Okay.
So you're going to need lots of medicines. And that's why I think these days with combination medicines, you actually can reduce pill burden and also at the same time get them the medicines they need.
So, Gene, for us that are taking care of these patients de novo before we send them to you, is it very likely or mostly unlikely that most of these patients can be managed with one medication? Because I think it is the habit of a lot of us in primary care practices in endocrinology, sometimes just to start with one. So can you give us a hint that when we might want to just go ahead and start with the two medications right off the bat?
Well, the recommendations are by the Joint Commission that if you're 20 over 10, 20 systolic over 10 diastolic above your goal, you start right off the bat with two medications.
And that is an important thing for our audience to remember, is that if you're markedly hypertension, start with two. And then any suggestions, or maybe you're going to teach us which ones are the best ones to use
Correct.
here?
If you're going to start with two medicines, the recommendations are usually a thiazide-type diuretic and an ARV or an ACE inhibitor, depending on the patient and their needs. The only issue, though, is if they're creatinine at 2 or above, then probably you should need to start with a loop diuretic plus a secondary agent like an ACE or an ARV, because once the creatinine is 2, a thiazide-type diuretic really is not very efficacious.
Okay. I learned that when I was in school. I'm glad that's still the truth.
So like we talked earlier, does medication type or class really affect the progression of nephropathy? And really, it is. I mean, the blockade of the renin-angiotensin-aldosterone system, people often forget the aldosterone part, is an important key in slowing down progression of renal disease by its effect on the kidney and other organ systems. And right now, the original drugs that came out back in the late 80s when we were training were the ACE inhibitors. And they block the conversion of angiotensin 1 in the periphery to angiotensinogen, that eventually binds to the AT1 receptor and interrupts the feedback loop to reduce renin down at the kidney level. And then in the 90s, 10 years later, came the next group of a class of drugs, which are the ARVs, which actually block the AT1 receptor directly. And more recently, about 3 years ago, we actually have the first new class of drugs in over 10 years, which were the direct renin inhibitors. There's only one right now called allosterin. And what it does is it binds to the cleavage site in renin and prevents the conversion of angiotensinogen to angiotensin 1. So it blocks the pathway right at the top. And the reason they came up with that is mainly because the body has ways around our best efforts to control blood pressure.
Right.
There are patients who have ACE escape, and there are other actually conversion enzymes that are not affected by ACE inhibitors that can produce angiotensin 2. And as well, at the level of the AT1 receptor, it's not 100% binding. It's maybe 80% binding, and depending on the level of Ang2, because of the interruption of the feedback loop, you can actually have displacement of the ARB from the receptor. It's not a covalently bonded drug.
So for all of us who are seeing patients not respond to ARBs in some cases, including some of our listeners, I'm sure, this is not an unexpected event for some patients, based on what you've said. This is a beautiful diagram of the physiology that a lot of us have understood. Renin is not what we want. So everything we've been using right now to try to improve blood pressure starts out with various agents to block it.
Exactly. Now, how do we know that these drugs work? Well, actually, it was not that long ago, in 1993, when the first study came out in type 1 diabetics. And this was a landmark study. And
Still is.
at the time, they used captopril because that was the only drug available. And in patients with type 1 diabetics who had frank albuminuria, it really slowed the progression of nephropathy, actually independent of blood pressure control. So this is the first time you could show that not only blood pressure control was important, but the type of drug you use to control blood pressure to control the blood pressure helps. So the two groups, they had equivalent blood pressure control, but the patients on the captopril had much slower progression to doubling of creatinine, dialysis, and stage renal disease.
This is a paper that many of my patients with type 1 diabetes actually are familiar with. It's hard for me to believe that it's been 17 years since.
Yep, it's hard to believe, but it's true.
Believe.
Now, since that study, they did the same thing with ARVs in type 1 diabetics.
Okay.
And unfortunately, ARVs are never studied in terms of progression of renal disease in type 1 diabetics. So we can't say it's exactly the same, but we know in type 2 diabetics that it does work. So in type 2 diabetics, and again, this is all a pharmacy marketing thing, they studied the use of ARVs, and it has, again, shown to slow the progression of nephropathy independent of blood pressure control. In type 2 diabetics, ACEs have not been studied, but except for mortality, and this is the ramipril study.
That's right.
So we know that in type 2 diabetics who are on ramipril, according to the study, the risk of cardiovascular events and death is significantly reduced.
So let's go back to our patient. She's got blood pressure elevation. ARB or ACE in a patient with type 2 diabetes, or does it matter? You know, based on what you just told me, I mean, we're going to improve her mortality with ACE and improve her renal disease progression with an ARB. Help me decide which one to use.
Right now, I would say an ACE. For several reasons. They're generic, and so patients who have problems affording them can't afford them. Okay. And they work effectively at controlling blood pressure. The only caveat is if you have a patient with a tendency towards hyperkalemia, you have to be very careful with an ACE, and you may prefer an ARB, which has a much lower incidence of hyperkalemia. Most patients we start on ACE, we often will check a serum potassium and creatinine level 3 to 4 days later, just to make sure we haven't had any adverse events. And in terms of creatinine, you know, even with an ACE or an ARB, you know, we can accept up to 20-30% rise in the creatinine because we know long-term that's protecting the kidney. Okay. And that's actually a pearl that many of us in primary care and endocrinology may forget because we get worried about the creatinine dumping up with these. Correct. So this is kind of a complicated slide, which the important thing is this is looking at irbesartan in diabetics with microalbuminuria. So they have established disease at an early stage. Okay. The first slide looks at the incidence of patients, of proteinuria in these patients over time. Okay. So over time, the dark bar patients on no ARB or ACE therapy. And the second line is on low dose and third line high dose ARB. Okay. And as time went on, the patients on the higher doses of ARB had a much lower incidence of developing frank proteinuria. And that's the first bar there. That's the first bar. What's the second bar there? The second bar shows the reverse. What's the chance of actually reversing proteinuria from microalbuminuria to normal albuminuria? That's what the patients care about that. So here, as you use high-dose ARB at 300 milligrams, for example, you had a significant number of patients convert from microalbuminuria to normal albuminuria. So this is when we are checking the spot, correct, like we talked about at the beginning. And suddenly it disappears. And over what course of time? A year? 2 years? I think the study was at least a year. And so do you titrate up? You try and titrate to the maximum tolerable dose. Okay. Okay. That's important for us to know. And good news for patients. Yeah. And here's the actual study I referred to earlier, the IDNT study looking at the two patient groups. So the lower line, which is the slowest progression line, is the one patients receiving irbesartan. The upper two lines, which are almost superimposable, are the amlodipine and placebo groups. Okay. So ARB by itself is good. Okay. And blood pressure control is good too. Good. Repeated continuously. Exactly. Now, a lot of questions I get asked now, well, if one drug is good or two drugs better, two drugs affecting the same system. Okay. And in theory, because of the escape pathways and not complete inhibition of receptor blockade, in theory, combining an ACE and ARB should get you even further blockade of the system. All right. So in non-diabetic proteinuric renal diseases, you know, like IgA nephropathy or membranous glomerulonephropathy, there's a study showing that the two together can slow progression to renal disease, and this is the Cooperate study. So the lower yellow line is the combined group, and the upper lines are the single monotherapy groups. Okay. The one problem with Cooperate, there were some issues with it, and it turns out a lot of the patients may have just had IgA nephropathy, which is a very slowly progressive disease. So this study has to be taken, you know, with that understanding. And not applicable to our patient or our patients. Right. Now, we know that in our patients in general, combined therapy will lower proteinuria. Okay. But all those studies are basically 6 to 12-month studies looking at proteinuria as a surrogate marker in progression. Okay. But most of them have not looked at real progression, like doubling a creatinine, dialysis, death, the big ones. And so in the Lancet and also New England Journal of Medicine last year, there were two studies that came out on target. And one was on-target data was used both in the Lancet article and the New England Journal. And what on-target was the use of telmisartan at 80 milligrams versus ramipril 10 milligrams, or both together, on patients over the age of 55 with vascular disease, not diabetes, vascular disease, or diabetics with end organ damage. So The study population in this group were mixed. It was not just pure diabetics.
But a lot of our patients with diabetes have vascular diseases. Sometimes we may not
Exactly.
diagnose, so there may have been a crossover.
Exactly. But what they looked at was the outcome of doubling of serum creatinine, dialysis, and death in the Lancet paper. And the median follow-up was about 56 months, so not bad. And if you look at the combined incident of endpoints, basically temolsartan and ramipril did worse than either agent alone.
Okay.
So from this, you say, well, we may be doing a disservice to our patients using both drugs.
Okay.
But again, the problem is this is not pure diabetes. These patients had 30% were only diabetic, 70% had just vascular disease, and so we can't say for sure this is true or not.
But you're not telling us it's absolutely contraindicated to combine them, nor should we do that as a first step. So it's sort of patient-specific.
And we will use it. And the reason we use it is patients have such severe proteinuria that they're edematous and they're miserable, and, well, we don't have other choices to reduce their proteinuria.
But in our patient, ACE first, check microalbumin over the course of a period of a year or two, see if we see improvement. If not, and everything is stable, blood pressure is not a goal, it is not inappropriate, based on what you've just said, to consider adding an ARB.
Correct. But I wouldn't do it unless the proteinuria is really jumping up.
Jumping up, okay.
Jumping up.
Okay, that's very helpful.
Okay, because, again, these are not FDA-approved uses for these medications.
Okay.
And so in the Cooperate study, this is just the different groups looking at decline in GFR. But again, the problems were the blood pressures were not equivalently controlled completely in these studies. They were not a pure diabetic population.
Okay.
And most patients at the beginning of the study really did not have either micro or macroalbuminuria.
Okay.
And so not applicable to the patients we're talking about right now.
Very good.
Another study just came out actually late last year, in New England Journal of Medicine, looked at the renal and retinal effects of enalapril and losartan in type 1 diabetics.
Now combined.
Exactly. So, and this was actually a renal biopsy study, so they got tissue. But these patients were normotensive and had normal albuminuria, so these were very early on before they ever had any evidence of disease. And they actually did a serial renal biopsy study. And over 5 years of the study, in terms of the kidney, they could not find any structural changes occurring. And if you look at albuminuria in these patients, 6% of placebo patients develop albuminuria, 4% of enalapril, and 17% for some strange reason of a percent of losartan patients. But in terms of retinopathy, either drug did lower retinopathy.
So you were able to, in this study...
And this was not combined. They did not use losartan and ramipril.
So they randomized them to separate arms. But you were taking essentially de novo, relatively healthy patients with type 1 diabetes before they had any observable problems and just seeing if you could prevent.
Exactly. And that has always been an issue. Now, do we start these patients who have normal blood pressure and no proteinuria? Do we put them on an ACE prophylactically or not?
So what's the answer to that?
And according to this study, if you're type 1, no.
No. So if we, and this is very pertinent to our listeners, if you've got patients with type 1 diabetes who have had it since they were young and they are showing no evidence of microalbuminuria, there is no benefit right now.
There's no good evidence to put them on an ACE inhibitor prophylactically.
All right.
The only problem with the study, again, was the 5 years. But, in a type 1 diabetic, it may take 10 or 15 years to see the full process. So this may be negative now, but if they kept following these patients for another 5 years, you may see more differences.
So we need to follow this study and see what happens if
they're following them.
So for us, practically, we need to be on top of checking the urine microalbumin and keeping the blood pressure.
Exactly.
Excellent. Okay.
And here's the graph just showing that we talked about. And then finally, in the Annals came out another paper almost a month after the last paper, looking at the effect of candesartan on microalbuminuria and albumin excretion rates in diabetics. So these patients were normotensive for the almost entirely, and really did not have significant albuminuria. So again, mainly type 2s as opposed to type 1 in the previous paper.
Like our patient.
Normotensive with normal albuminuria. And over the course of the study at 6 years, candesartan did not really change albuminuria development.
So far you've said, and this relates to our patient, not directly because she's got an elevated blood pressure, so we're going to need to aggressively manage that. But if you've got patients coming into your practice with type 1 or type 2 who are normotensive and have no proteinuria, that microalbuminuria, then right now, based on evidence that has been recently released, it does not appear that prophylactic use of either an ACE or an ARB may be indicated?
Correct.
Okay. But there's a lot of buts in there.
And the but is that, again, this is a 6-year study, and this may take another 6 years to show benefit.
Okay.
But if there's any reason to start a drug, then we would start with an ACE or an ARB.
So low threshold and blood pressure is the driver.
Blood pressure or the albuminuria.
Or the albuminuria. Okay.
Now, recently, as I mentioned earlier, the new drugs have come out, the new class of agent. But as I mentioned earlier, it suppresses the formation of angiotensin 1 at the point of activation of the system. This drug, I should say, because there's only one right now, does lower blood pressure. And it does have, and when it first came out, there was no indication for use in albuminuria. Right now, it's only indicated for blood pressure control. Okay. But the company did sponsor a trial in diabetics with albuminuria, and this came out in 2008, again, New England Journal, looking at losartan versus by itself and in combination with this drug in type 2 diabetics with frank nephropathy. So they had over 300 milligrams of proteinuria, but less than 3 grams. They weren't frankly nephrotic. And and this was a study looking at maintaining equivalent blood pressure control and seeing what happened to their proteinuria. Right. So blood pressure control is pretty well matched in 2 groups. There's a 1 millimeter systolic difference between them. But over the 24 months of the study, you could see a significant lowering of albuminuria. Basically, there was about a 20% reduction in albuminuria in patients receiving both losartan and the renin inhibitor allostarin compared to losartan by itself, which is the upper line.
So the upper line is just the losartan. The bottom line is a combination of both drugs done sequentially?
All patients started off on losartan, and then they either went to the placebo arm or they received the starting dose of allostarin, and at 6 months they were up titrated to the maximum dose.
This looks like data we need to keep an eye on.
It is, and the important thing is that out of that 20%, 25% of them actually reverted to microalbuminuria.
Well, that's great.
So there's actually a major study coming out, or ongoing right now, and hopefully results out 2011, 2012, looking at renin inhibitor on top of either an ACE or an ARB in hard endpoints in diabetics.
So you're taking that circle you showed us and we're hitting it at a couple spots in an effort to decrease the blood pressure and the proteinuria. That's
exactly.
Great.
So lastly, just talk about aldosterone blockade, because aldosterone blocking drugs have been around for a long time. And there is evidence to suggest that even with 25 milligrams of spironolactone a day, you can reduce proteinuria. The problem with all those studies are that it's not quite tight blood pressure control. I mean, there's some slight differences between the groups. Right. And the problem with the spironolactone on top of an ACE or an ARB is hyperkalemia. So, further studies are ongoing and needed. But, if you're really desperate for blood pressure control and trying to reduce proteinuria, that may be an added option depending on your patient. So, as I said before, blood pressure is the key to everything.
You said it several times. Blood pressure is the key to everything.
The most important thing you can do. And RAS blockade with either ACEs or ARBs and even newer agents are key to control blood pressure and management of the albuminuria. Combination therapy by itself does need further study.
Okay. Well, I think I have a plan for our patient. I think the endocrinologist or the primary care physicians give it a try first, since we're not meeting a lot of the criteria for referral, but it's certainly low threshold for referral to nephrologists if we can't get the blood pressure under control in a relatively short period of time.
Because other drugs they may use have a lot more side effects, and you have to know how to deal with them.
Okay. Our guest faculty today has been Eugene Kovalik, one of my colleagues here at Duke. Gene, thanks for joining us and leading such a great and very, very helpful discussion.
My pleasure.
Until next time then, from all of us here at Duke, this is Diana McNeill saying thanks for joining us and take care.